Good morning, everyone. It's my pleasure to welcome Alberto Rubio-Tapia from Mayo Clinic, the main one in Rochester, Minnesota. He is a most unusual person. He is a native of Mexico and first got his medical doctor degree from the National Autonomous University of Mexico in Mexico City. Then he did internal medicine training at the National Institute of Medical Sciences and Nutrition, Salvador Zubiran. And then continued his GI training at the same institution where he was also the chief medical fellow. Then he spent 3 years working as a postdoctoral fellow under the tutelage of Joe Murray at Mayo Clinic, world-renowned Celiac Sprue expert. After that, he redid his internal medicine training at the Mayo Clinic and followed now by his GI fellowship training at the Mayo Clinic. So he is trained fully twice and then some. He's completing his fellowship, but he is already an assistant professor of medicine at the Mayo Clinic College of Medicine. He is a highly accomplished individual in the world of celiac disease with many original publications on the epidemiology and management of these conditions, with 68 original publications, 16 book chapters, 13 editorials. He's very young and already has an H index of 24 for his publication record, which is very striking. So we're very pleased to have him visit from Mayo Clinic and looking forward to your talk, Alberto. Thanks so much.
Thank you. Thank you very much for the nice introduction. I'm very happy to be here. It's for me an honor to be in this institution that is so strong and academic center. So I have no relevant disclosures. My two learning objectives for you today is to kind of review the current epidemiology of celiac disease that has changed. And also, the last part of the talk is talking a little bit about the differential diagnosis of villous atrophy in the context of seronegative villous atrophy. Most of the talk is going to be epidemiology. I would like to present to you some emerging data that suggests that the current paradigm for testing, that is case finding, meaning looking for celiac disease in high-risk populations, may not be the best strategy. I don't have a good answer to what is the best strategy yet, but hopefully we can get some new studies and answers for that. And finally, the last part of the talk is going to be the differential diagnosis of villous atrophy. So I will start by asking you a few questions. So this is a personal clinical observation. This is not research. So this is a case, 32-year-old woman with IBS diarrhea, first time that is seen in the clinic. Do you test for celiac disease? Just raise your hand. I think most of us agree that it should be tested, right? And then I will show you two more. 55-year-old man with unexplained iron deficiency anemia, and 33-year-old woman with type 1 diabetes and chronic diarrhea. Do you test for that, for celiac disease? I think it's a kind of an agreement that we all recognize the clinical indications for testing in celiac disease. Well, I just show you three cases. These are real cases that I saw in the clinic, in the general clinic. And then for me to find one case of celiac disease, I have to go over 172 patients with clinical indications for testing. And this is a good start. At this, look at the case. It was a 22-year-old woman with bloating, like a very general common gastrointestinal symptom, with the only additional risk factor of having a second-degree family member with celiac disease. And this is my intention in terms of a problem here. So it's very frustrating looking for celiac disease, and I'm pretty sure that you have the same problem. You look for celiac disease and many patients with clinical indications, and you find just a few. So, but then as a way to give you a balance, let me show you this case. This is also a real case. 33-year-old with unexplained infertility, lactose intolerance for most of her life, no other GI symptoms, normal labs, a negative family history of celiac disease. She has been enrolled in the infertility clinic with the treatment that is the standard of care for this problem, 3 cycles of clomiphene and intrauterine insemination without being successful. And this is a note from the gynecologist asking permission to the patient to test for celiac disease. That is a little bit of unusual. So this is from the medical record. So you can see, since we are drawing blood tomorrow, would you be fine to add TTG? I realize this is a long conference I attended this year. They have mentioned that celiac disease can cause unexplained infertility without significant symptoms. Then they go ahead and did the tissue transglutaminase antibody that came back very elevated, 100. So I met the patient at the endoscopy suite, and then I continued to follow the patient. The endoscopy shows the typical findings of celiac disease. This is the distal duodenum, and looks like the bulb. So there's no circular folds. There is fissuring and all the other findings. And the histology shows villous atrophy. So then the diagnosis was made. So on follow-up on the gluten-free diet, patient did really well. Lactose intolerance improved. Serology, after 1 year of being on the gluten-free diet, is now normal with a TTG of 3.5. The plan from the infertility clinic was to do gonadotrophin injections with intrauterine insemination. But before that, 14 months after being on a gluten-free diet, she's pregnant. So for me, this is to show you the balance between being frustrating, finding the disease, and then how you can impact the life of a person when you look for celiac disease. So she is 12 weeks pregnant, so hopefully everything goes well. And this is a big thing in terms of case finding. So my interest also is to kind of emphasize that celiac disease is defined by the enteropathy, but it's more like a systemic disease. And the clinical presentation has changed over the years. So this is from the textbook, probably 25 years ago. We think about celiac disease as a child with malabsorption, malnutrition, poor growth, and we still see these cases, but it's less common. So nowadays, celiac disease is more like a multisystemic disorder. Clinical presentation will be just an abnormal liver test, some issues with the recurrent after in the mouth, iron deficiency anemia, or other types of anemia that are unexplained. The dermatitis herpetiformis could be the only clinical manifestation, and just the enteropathy is probably just one of the multiple manifestations of eating gluten in patients with celiac disease. And this is gluten. That is kind of impressive to see. It's not hard to think how difficult it is to digest. If you can look at this, the pure form of gluten. But where are the celiac patients? So we know that if we, in this picture, in Times Square, 1% of the population may have celiac disease. Sorry, I hope you hear me. So, okay, yeah, thank you so much. So to explain this problem, the celiac iceberg has been proposed. Basically, the visible part of the iceberg is diagnosed celiac disease. Most cases have classic celiac disease with malabsorption, but now we are detecting more cases with no classic presentations. But the majority of the patients are below the visible part of the iceberg, and they remain undiagnosed. And there are countries that they don't know the icebergs, but the same principle has been described. So this is the ear of the eyeball, and you can see the same idea. So just the visible part is small, and the big part of undiagnosed disease is below the waterline. And we have been dealing with this celiac iceberg in Olmsted County for several years. This is the first study that described the epidemiology of celiac disease from 1960 to 1990. And look at this. They described only 28 patients, 100% with diarrhea. So they didn't know anything about the hidden part of the iceberg at that time. And the conclusion was celiac disease is rare. And it was really, really bad in terms of how we approach the celiac disease in the US. And it is a big jump. So obviously many things happened between 1990 and 2018. But one of the things that happened is that serology is available. So then it was more easy to test for celiac disease. And in 2018, look at the change in the epidemiology of celiac disease. We have detected more cases, 410, in a population of 120,000. And just a minority, 30%, have diarrhea as clinical presentation. So the vast majority of patients with celiac disease have non-classical presentations. And we also did a very extensive serologic testing in the community, about 48,000 unique residents, to know the prevalence of the disease. And we know that it's 1%. So we know that the size of the hidden part of the iceberg is 1%. And in total numbers is 1,400, meaning that we have detected one case and we have 4 cases to detect. And this is the issue. Looking at the incidence of clinical diagnosis after we know the serological status of the patient. As expected in patients with no positive serologies, the incidence of clinical diagnosis was very low, less than 1%. But look at this. The incidence of clinical diagnosis 5 years after we know that the patients have positive serologies as part of the research study is just 5%. So we are detecting just a minority of the cases in the community. This is not unique for Olmsted County. This is a study we did using NHANES that is representative of the US population. And we checked serologies and also we apply questions, that is face-to-face questions about the clinical diagnosis in about 8,000 participants. We detect 35 cases with celiac disease. Most of them didn't know so that they have celiac disease. The only way we know that they have celiac disease is because the sequential serologic testing with TTG and EMA was positive. And also interesting, we found that a significant number of participants use a gluten-free diet without having the diagnosis of celiac disease. That was not the objective of the study, but it's becoming very important nowadays. So then with the conclusion of this study is that we have about 1.8 million people with celiac disease in the US with a population prevalence of 0.7%, but 83% don't have a diagnosis of celiac disease. And with this study, we describe the gluten paradox, meaning that we have the same number of patients with undiagnosed celiac disease that they don't follow a gluten-free diet because they don't know they have the diagnosis. And at the same time, the same number, they are using a gluten-free diet for a different reason than having the diagnosis of celiac disease. So kind of just a few cases with diagnosed celiac disease following the gluten-free diet, that is what is the right thing to do. But this is not the way it has been over the years. This is now like a classic study that I did that we show the prevalence of celiac disease in 1950 was 0.2%, and then we use current sample of in the population with the same year at year and the same age at time of testing that the original 1950 cohort, and we show that the prevalence in those two present day cohort was 0.8 and 0.9%. So there's a 400% increase in the prevalence of celiac disease in the US population over the past 50 years. Why is that happening? That's a very good question, and we don't know for sure. But this is not a problem for the US only. So this is a meta-analysis that shows the distribution of celiac disease around the world. And there's some heterogeneity in this study, but in general, the serology prevalence of celiac disease is 1.4%. The biopsy is 0.7%. And what is remarkable is in most cases in the world, 83 to 95% remain undiagnosed. This is a big issue. This is a meta-analysis that we did more recently. And again, to show you that there is a global distribution of celiac disease, there is important regional variations. And even in undiagnosed celiac disease, and that is kind of a new finding in this study, the prevalence is higher in women as compared to men. So what is the new phase of celiac disease? So we knew for many years that the higher prevalence of celiac disease, 5.6%, is in the Sahrawi population in North Africa. But now there's evidence that is very strong that suggests that in India, the prevalence of celiac disease may be between 0.5 and 1%. And I'm not good with math, but the India population is 1.3 billion. You can calculate how many celiacs they have, and it's significant. And the question mark is there just to ask who is the next patient, that the next country that will know that celiac disease is frequent, but they just don't know right now. And probably Russia is the candidate. They have some emerging evidence that the prevalence is 0.8%, and they obviously didn't know that they have this prevalence. So I will switch a little bit to incidence. There are very few studies in terms of incidence at the population level. We have the opportunity to do population-based research, and I can show you this incident picture from 1950 to 2010, and you can see how the prevalence of clinical diagnosis was very low over the years until around 1990, when we start seeing an increase in the incidence of celiac disease both in women and men. And the reasons for that have been proposed, and it's more like a speculation. Maybe it's because the serology is available, there's more awareness about the disease, there's no question about that. Doctors and patients know more about the disease. There's an increased burden of the disease, there are more cases. We show that also. And most of the explanation has been given to case finding, meaning that we are doing a better work looking for celiac disease in high-risk populations, and I would like to challenge that. So this is the current testing paradigm. You can see this picture, all the clinical indications that are accepted for different guidelines for testing for celiac disease. And could be non-classic, classic, or at-risk conditions are associated disorders. It's a big list, and the idea of looking at celiac disease in these conditions is to detect the disease early and hopefully help the patients with the symptoms. Making it easy to find the needle in the haystack, but the evidence suggests that maybe the needle and the hay are not that different. Let me show you this. This is a summary of a recent study that we did. It's a case control study, 14 cases with undiagnosed celiac disease compared to 400, compared against 400 referents, age and gender match. And then we look at the electronic medical record without knowing who was undiagnosed and who was a referent, and look for the frequency of indications for clinical testing for celiac disease. If case finding is good to detect undiagnosed celiac disease, then what you expect to see is more increased proportion of indications for testing in the undiagnosed celiac disease group as compared to the reference that they don't have undiagnosed celiac disease. And the finding was that the frequency was exactly the same. So 40% for undiagnosed, 37% for reference. So what that means is that the current indications for testing for celiac disease were unable to differentiate between the two groups. That's kind of shocking. And if you apply this to the target population that was 45,000 residents, and you look at the 400 that have undiagnosed celiac disease, you have only 159 with indications for testing, but the vast majority, 241, they don't have any indications for testing. That's 60% of the patients with celiac disease that are undiagnosed will remain undiagnosed no matter what, even if you apply a perfect case finding strategy in your community. And then look at this. This is what I'm seeing in the clinic. So to detect this 159, you have to test about 17,000 patients or persons without celiac disease to detect those cases of celiac disease. And the prevalence of the disease here is 0.9%. That is not different to the general population. Basically, it's not adding more to the general screening in terms of using the current indication for testing. So we have a problem here. I don't have a good answer yet how to fix the problem. But this was modeling, just an estimation. Let's go to the real data. This is unpublished data. Look at this. This is the celiac incidence from 2000 to 2015. And you can see that it has been increased until around 2000. Continues to increase, but the rate of increasing is slower now. But the rate of testing in the community is going up, and we are not detecting more cases. So this is very interesting. And if you look at what is the proportion of positive serologies in the community, in 2002, we have a 7.9% of positive serologies. Most people suggest that case finding is good if you detect above 5%. Now, some people suggest that 2% is good because it's still above the 1% of the general population. But look, but look at this. Starting around 2006, the proportion of positive serologies has dropped dramatically. And more recently, from 2014, 2015, and up to 2017, I can tell you that it's below 2%. So we are looking for the disease, but we are not finding the disease. And this is what happened. So this is the proportion of doctors that test for celiac disease in our community. Most testing is by primary care doctors. That is what we want, because that's the way we like to detect celiac disease. And the proportion of positive diagnosis is higher in GI doctors, 11%. There must be some referral bias there. That explains that. But for primary physician, it's 3.3%. So then when I go and do talks with the primary care physicians, and they ask me and tell me, I'm looking for celiac and I don't find it, they are right. So they are not finding it. And it's very frustrating. Look at this. There has been a change in who is looking for celiac disease, with more and more primary care physicians looking for the disease in our community. That is what we want. So in terms of the indications and positive serology, you can see there are some indications that are better than others, like family history of family members with celiac disease is really good, 12% positivity. Weight loss, 8% positivity, around 5%, 4.4%. So I think this is probably the answer. So we will need to be more strict at who we are testing for celiac disease, but that is still kind of an ongoing work. And I will stop there in terms of the epidemiology and the kind of problems with the current testing paradigm for celiac disease, and I will move to the differential diagnosis of villous atrophy. This is what I propose is probably the best way to look for celiac disease in the present time. And then when we have issues in terms of the differential diagnosis of celiac disease, is when we have a negative DQ2, DQ8 the patient has pilus atrophy and is not celiac. So then what is the problem there? Or then the other problem is when the patient has negative serologies, the biopsy shows atrophy, the patient has no seronegative celiac disease, then that's when we start thinking about the differential diagnosis. And this is a very, very important clinical problem at the present. Celiac disease, the gluten-free diet is excellent for patients with celiac disease. There are multiple benefits, but also there is a lot of challenges for the patients in terms of how to implement the diet and the cost and many, many other reasons. And the most important thing is that the gluten-free diet usually don't work for other enteropathies, and they just don't get better. And this is when you need to suspect other disease. When the patient has no DQ2 and DQ8, sometimes we try to put the patient on a gluten-free diet and try to see if the patient gets better. I think this is probably a waste of time, because if you don't have the genetic background for celiac disease, your chance to have celiac disease is very, very small. When the patient has a lack of response to the gluten-free diet, you need to start thinking about, do I have the right diagnosis? But they have a negative serology with normal IgA, seronegative celiac disease is very infrequent. You will see it, but it's very infrequent. And the absence of intraepithelial lymphocytes is also another reason to think about the differential diagnosis. And very, very infrequently, you have a pathology that is typical for other disease, and then you may have some clues there. So celiac disease is still the most frequent cause of pilus atrophy in the US, but there is a expanding differential diagnosis, including, I would say, drugs at the top of the differential diagnosis, Celiac, olmesartan, and others. Tropical sprue is very frequent in the US, but sometimes you can see that in immigrants or people that travel a lot to tropical areas. Small bowel bacterial overgrowth, 50% of the time they have pilus atrophy. So this should be part of the differential diagnosis. Parasites, like Giardia lamblia, very infrequent, like 3 or 5% of the time have pilus atrophy. So it's a very infrequent cause of pilus atrophy. And then you have all these groups of conditions that are very, very, very infrequent. Like, for example, Collagenous Sprue, we have the largest case series is like 20 years, and we have 30 cases. So they're really, really frequent. And most of the cases are related to olmesartan. So then it's kind of tough. CVID is a very frequent cause of pilus atrophy, so there's to think about it. And then, as I mentioned to you, pathology sometimes gives you the answer. This is really, really, really very infrequent. They tell you, like you have this biopsy and it's Whipple. Oh my God, this is like winning the lottery. It's very infrequent. And this is a case series. We put together like six clinical centers, and the total number of cases was 29, and it's over 20 years. So it's very infrequent. And then when you see something that is not typical for celiac disease, for example, looking at the biopsy and the pathology mentioned a lot of collagen, you need to start thinking about the differential diagnosis. And in this specific situation, I will say medications is one of the things that you need to start thinking about, like olmesartan. And I will just show you this because by following this very, very easy steps when to think about the differential diagnosis, we were able to describe a new disease, that is this association between sprue-like enteropathy and olmesartan. And you can see how these cases, there's 22 cases, they have negative serologies. The patients didn't get better with a gluten-free diet, and the biopsies shows not just enteropathy. For many of those, shows also collagen. That is not typical for celiac disease. And now we know that after withdrawal of the drug, the clinical manifestations improve, and also the biopsy in those patients. So just to summarize, the take-home message here is celiac disease is a global problem. We need to think about the systemic manifestations and associations to detect the disease without diarrhea. And I think you do that, and just think about the issues with the case finding paradigm. Don't be frustrated. You will look for the disease. Most of the time, you will find nothing by doing that. Sometimes you may find the case that you make a difference for life for the patient. Celiac disease epidemiology is changing, and it's very interesting to try to study why that's happening. And there's a very wide differential diagnosis for venous atrophy, and I think a review of the medications during the first visit is very important. Thank you so much.
Great, thank you, Alberto. Really great talk. And of course, no one can do natural history studies better than Mayo Rochester, so it's a very unique resource. But I have one question for you. So if what you find is there's so many undiagnosed cases and that some of that, you said 60%, don't even have an indication for screening, why should we be looking for those cases? In other words, what are the consequences of undiagnosed celiac disease?
Yeah.
Why would we want to make sure we find every single case?
So that's a very controversial topic, but there is some suggestion that having undiagnosed celiac disease may impact the survival in long term. For example, we did the same study that we did in 2009. We look at the survival over 50 years in patients with undiagnosed disease against reference without undiagnosed disease. There's a drop in survival of 400 times. So there's a difference of fourfold difference. So
the specific diseases associated with that.
yeah, that's the problem. The numbers are not sufficient to kind of claim that. We don't know for sure.
That's from Olmsted County data.
That's using the Warren Air Force data. That has been used for studies of heart disease, rheumatic heart disease. So we use that sample to look at.
Which is how large is sample?
It's very large. It's about 10,000. There are young men enlisted in the Air Force that we follow them for a long time, and they have this difference in mortality over the years. Obviously, it's interesting to see those changes in men because the frequency of celiac disease now we know for sure is more. It's not just that we detect more in women; it's more frequent in women. We don't know why, but it's more frequent in having undiagnosed disease. So I think the burden of undiagnosed celiac disease may be higher in women, but we just don't have that study.
What is the influence of the gluten intolerance, say, this fantasy area of diagnostic ability?
Yeah, that's a very, very, very good question. So it's very hard right now in the clinic to see a patient that has the question of celiac disease, like the personal question of the diagnosis of celiac disease, without having a gluten-free diet on place. So that makes the diagnosis more difficult. So my suggestion is what I do is first I ask them, do you want to stop the gluten-free diet if I give you the diagnosis? Do you really want to know? Because that seems like a not important question, but it's very important because they have to go for testing and maybe end it in a gluten challenge. And if they don't want to do that, then it's very hard. So then at the end, some of the visits, the conclusion is, I don't know if you have celiac disease or not, but you are doing better on the gluten-free diet, and then you are happy, and I don't fight against success. That's my personal view. When they really want to know, I usually check serology, thinking that it's positive, it will give me some information. It's negative, it's useless, and then I go to the genetic test, and about like 40% of those specific cases have negative genetic tests, and then you are done. You can say you don't have celiac. This is a different thing, but then the most difficult part is when they have the positive genetic test, and then to sell the gluten challenge could be very difficult.
Okay, the double test positive, yes. What about if it's just an HLA2 or just one?
Yeah, I think it depends on the ethnic background. For example, if it's Hispanic or is Mexican, DQ8 is more frequent. So then I will give a lot of value to that. And if it's DQ2, it's the predominant in white, non-Hispanic whites. But still, if they have DQ2 and DQ8 positive, then I will go for the challenge if they really want to know.
Can patients with CDID also have celiac sprue, and how would you diagnose it?
Yeah, so that's a very good question. That's very frequent. I have experience with that because in Mexico I have this series of small bowel lymphoproliferative hyperplasia, and then by looking at those specific patients, I identify the CVID cases, and then that they have the same histology as celiac disease, but just lack plasmatic cells in the histology. And in that group, that is about 22 cases, 2 of those cases have endometrial antibody positive. That is very specific for celiac disease, and they get better on the gluten-free diet. But it's most of the time is a mimicker. They have atrophy because of something that we don't know very well why, associated to CVID and not celiac disease. And
so anti-endometrial antibodies would clinch that for you?
That would be probably the way to go. Yeah, if the anti-endometrial antibody is positive, it's very specific in that situation.
No.
It has to be IgE.
So you know what? I don't like it.
Which part?
This epidemiology. You know this iceberg? I have seen that at nauseam 40 years. You know, and my point is that why should we look for celiac disease in patients who have no symptoms? Because when you look at their quality of life, we put those non-patients on a gluten-free diet. Sometimes they will become symptomatic because they will become IBS, which is very common. And the good question is a question asked by Bruce, what's the long-term consequences? You know, when I started like you many years ago, I was very excited by that. How many T-cell lymphoma have you seen in your life?
Very few.
I think he's
I've
saying.
seen one.
I think what he's saying is the hippo is only ears.
Yeah.
And the point is that, no, but I think it's a real problem, and I believe the people working in celiac disease want to make a lot of noise because they want to get grants for that. But I don't believe it's a huge clinical problem. I mean, you need to show me this is a huge clinical problem.
But Jean-Fred, if you saw long term, there was a 4-fold increase in mortality.
This is not true in all studies.
Yeah. So
This is not true in all studies.
So I totally agree with your point. So it's a
Maybe I mean it's
no. I think and yeah. So what is missing is the evidence to strongly suggest that we need to look for those cases. So that's the evidence that is missing. It's a lack of evidence, not that the evidence is against that.
So the most important question in your field.
It is. I think that one of the most important questions is that, and I think this information that I show you about the difficulties with case finding may put the celiac teams together to finally do what we need to do. That is, it's a long-term multi-center study looking at what is the outcome of undiagnosed celiac disease without symptoms long-term. And if it's any difference treating the patients, but because that information, I totally agree with you, is not available.
So along those same lines, if you take an enriched population of everybody with iron deficiency anemia, or everybody with osteoporosis, or everybody with infertility, and then look for celiac, what's the prevalence in those enriched?
Yeah, so those are kind of high risk groups. For example, for iron deficiency anemia is about 8%.
8%?
Yep. For infertility is 44%. And what was the other?
Yes, osteoporosis.
Osteoporosis is very tricky
Yeah.
because it depends on the age when you test. And if you test people that is young, you include males, then maybe an enriched population, but it doesn't go above like 3 or 4%. So still, if you look at those high-risk populations, most of your testing will come back negative. But it's important,
But
right?
still higher than
That the 1%.
in unenriched.
Yep.
So an expert has a question for an expert.
I always love your talk. So I had a question. I got 10 o'clock last night. There was the email blast about this I'm Aware campaign, which is the organization that we're part of for celiac disease, partnered with this company that's marketing direct to patients to get themselves tested. So they're using a panel. It's TTG, DGP, A, DGP, G. So I'm just wondering, like, what do you think about that? Because I think it's great more people will get diagnosed. It's $165, and then patients can walk to their doctor and say, hey, I tested positive, or my DGPs are positive, or my IgA is negative.
It's very risky. I'm against the panels because the high frequency of false positive, like especially with IgE, in the context of being IgA producer. So that is of no value, and it will end with a lot of stress, anxiety, and probably unnecessary endoscopies. So I don't know the specifics and the details about that.
It looks like they sent it out last night. Someone had mentioned it to me this week, and Stefano from Chicago was on the board, so it's just kind of interesting.
Jim, has there been any work done? I mean, $165 would get you, a meal for two gluten-free in Manhattan. So a lot of it, right? Does anybody? Yeah, maybe. What is the cost of? Has anybody looked at the cost of all of this serologic testing, and then the consequences of that in terms of endoscopies, this work? Is that ever been looked at? I mean, this feels like the osteopenia of gastroenterology to me.
So we did a study on cost at the population level in 2006, but it's just for clinically diagnosed cases. And what we found is that the cost of having the disease without diagnosis was in excess as not having the disease, just because they are using more resources. And then after the diagnosis of celiac disease, during the first 3 months, there was some increase in incremental cost, but after that, there was a saving of about $4,000 per year after having the diagnosis. So it seems like not having the diagnosis in patients that have symptoms increase the cost. And then after having the diagnosis, the cost for the healthcare system is
So these are symptomatic patients.
It's patients
Right.
with,
So this, the undiagnosed underberg.
yeah, the undiagnosed, I'm not familiar about any study.
Underberg?
Yeah, the soft underbelly and the boat. Dave.
So Peter Green's talked a lot about olmesartan, is celiac disease. I had a patient last week who's a kidney transplant patient who's on Celiac, who had diarrhea, so they were all worried about infection. I biopsied her duodenum, and she has celiac disease from the Celiac, I'm assuming. Do you know the incidence of the other side of that, which is like how many people who get olmesartan get sprue, or how many people who get Celiac get sprue?
So there's no studies about that, so we don't know, but it's very infrequent.
Infrequent.
So, yeah, very infrequent. So the big clinical trials, with the medication, they don't show any signals, but about the risk. There's also a French population study that look at all patients using all IRBs, including olmesartan, and they show that there's no signal in terms of increased risk at the population level, but there's no doubt that the cases are there.
Jump in.
So I have one question. There are very interesting data about possible infectious trigger of the disease from inflammation of Referents and this rhinovirus and so on. We have also some data about this actually. So what's the state of the art?
I think there's some evidence that infections could be trigger for the disease, not just virus, but also having, for example, infections, bacterial infections in childhood increase your risk of developing the disease in adulthood. So what is the specific Is this an association? Is this a cause and effect? That we don't know. But there's some. Is this having this infection is a trigger for losing your oral tolerance, or this is pathogenic? So we don't know. There's some proponents like Panajabri that maybe some molecular mimicry between the virus and the gluten peptides. But I think we need to wait and see. Yeah.
Sure.
What is the association of celiac disease diagnosed with other autoimmune diseases?
Very strong association. And
What specific autoimmune?
yeah, so there's a strong association, for example, with lupus, with Sjogren's, with rheumatoid arthritis, with thyroid disorders, autoimmune disorders of the liver. So that's where the association is very strong. It's very interesting because, for example, your risk of autoimmune disease in the general population in the US is 6%. If you are a male, your risk is even lower than that. Your risk of autoimmune disease, if you have celiac disease, is about 30%. If you're a female, if you're a male, it's 28%. So it's a significant increase in the risk of autoimmune disease. And again, I think the issue is this an association because there's a shared genetic background, or this is having the celiac disease and gluten and loss of tolerance increasing your risk of developing disease? Like it has been the question for type 1 diabetes. That if there's some mouse model that if you treat the mouse with gluten-free diet, you reduce the risk of developing diabetes. So that's very, very intriguing, but we have not seen that in humans.
But so if you are on gluten-free diet, you are decreasing your risk of developing other immune diseases.
That's a very good question. I'm not 100% sure about that. There's sufficient data to say that.
And by the way, since this is Mount Sinai, we can also say that there's genetic overlap with Crohn's disease as well, with inflammatory bowel disease. And I think actually we underdiagnose it and probably undertest for it in our IBD patients.
CD here is Crohn's disease.
Right.
CED, celiac.
Not a propensity.
Alberto, thank you so much for.
Thank you so much.